morning, everybody. My name is Dr. Cohen. I'm going to be speaking about how to work a microphone. Okay, today we're going to be talking about complementary medicine in breast cancer, in specific metastatic breast cancer. I want to thank everyone for coming down. I want to disclose I don't work for any pharmaceutical companies. I get no money from any pharmaceutical companies. And the drug representatives will know that I don't even talk to them when they're in my office.
Once in a while.
Nor do I eat their lunches. But I thank you for sending them.
Yeah, thank you.
So I think this is I was assigned to this topic, usually not a topic I talk about this. We're not going to be talking about chemotherapy at all today. We're going to be talking about therapies that are in addition to or alternative to standard therapies. And as you know, if anyone who has someone going through cancer treatment, especially metastatic breast cancer treatment, is that I would say most people do some form of complementary alternative medicine in addition to the standard therapies that are out there. So it's not such an unusual topic. You'll see that a lot of things complementary, which means in addition to the standard therapies, are done by patients. And we're going to go through them. And I actually, since we're such a small group, it'll be great if we're very interactive. So if someone has something they want to say, they could either shout it out, you don't have to raise your hand, but we can be really interactive about this. And what I'd like to do today is go through some of complementary medicines that are out there that you might have heard of. We can talk about other things and also talk about the research that's involved in complementary medicine and where is this field really going. So without further ado, let's go to my first slide. Complementary medicine is different from alternative medicine in the sense that complementary medicine complements the standard of care of medicine. So there are chemotherapies that we give to our patients, whether it be targeted therapies, hormonal therapies, immunotherapies, and those therapies are standard as complementary medicine, just complements the addition of that to the standard therapies. Alternative medicine typically will mean, and it can be the same therapy, but it means you're not doing the standard therapies, you're doing something alternative to it. So as opposed to in addition to, it's the exception, not in addition to. So there are different types of complementary medicine. There are natural products, there's mind-body things, there's whole medical systems. And these, as I said, and I started off saying, they are commonly used. I mean, we're going to go through a list of some complementary medicine, but I can tell you most people use some form of complementary medicine to get them through it. And when we're speaking of complementary medicine, we are usually talking about things that are to improve someone's quality of life while they're on their therapy. And we're going to also go through that as well. And, you know, the funny thing is you see on TV and you see patients say, well, doctor, it's natural. That does not mean it's safe. Just to be, you know, I was just on the way here, there was a story about mushrooms and Ellis, you know, causing hallucination effects that they want to make legal. Mushrooms are very natural products that you can grow in your house, but that doesn't mean it's safe to do it, and you have to do it in the right setting, and you have to be careful with what's out there. But I would tell you that a lot of complementary medicine is actually safe to do, and really, I think the theme of, or the take-home message that I want to impart to everyone is that if you do complementary medicine, as long as it's safe, to me there's no downside of encouraging a patient to do these forms of therapies, as opposed to therapies that may be harmful or may interfere with therapies. Then those are not advised. But a lot of therapies that could be complementary could be simply giving some empowerment to the patient, which is important from a psychological point of view, and also could actually help patients in terms of quality of life. So just as a aside, natural does not always mean safe, and you have to think of what the therapies are prior to starting any therapy. So natural products could be soy, and I think we can skip over soy a little quickly because soy has its own controversial aspects related to breast cancer in specific, whether it's natural soy or a phytoestrogen soy. And there's studies that are being conducted, but these are very difficult studies to conduct at the NIH in terms of what soys are healthy and what is good for patients. There's whole medical systems, which is Chinese medicine or Ayurvedic medicine in India. These, once again, are not standard therapies. And this is a study that showed in 2015 that up to 30% of breast cancer patients use these forms of therapies. I would guess in my practice it's like 99%. I mean, I don't think there's a person that should be on some complementary form of medicine if they think that could help them. So let's go over some complementary forms of medicine. And if you could look at this, I actually want to key in on this, because any form of therapy, art therapy, pet therapy, music therapy, or any just plain old therapy could help someone with their quality of life. You know, psychologically going through a diagnosis of breast cancer, whether it's in the adjuvant, meaning the early stages, or metastatic setting, is a tough thing to do. And everyone has to deal with chemotherapy and side effects, and any form of therapy, whichever works for the patient, is a helpful thing. There's vitamin therapies, including vitamin C and D, which we're going to go over in specific in a minute. There's B12 therapies, there's massage therapy, which I think should be encouraged every day, as long as you have a good massage therapist that doesn't charge you. That's a great therapy. There's prayer and distant healing, which I could say that people do use it. I had a family member who used distant healing. I could tell you that I wasn't really keen on it because I was the one paying the bill for the distant healer, and I didn't think they were doing anything. But on a psychological level, once again, if you're going through a major struggle in your life, to have all the forces behind you and you feel like you're controlling something in your situation makes perfect sense. And no doctor, or at least I will never tell a patient, don't do that if it's not harming you. If you think it's helping you, great. There's something called therapeutic touch. There's Reiki therapies. Actually, in my office, some people will know that we have a Reiki therapist come by, and it probably looks a little weird for the patients who are next door to the patient who's getting Reiki therapy, as opposed to, you know, they must wonder what's going on there. But these are forms of therapy and hypnosis as well that are helpful as complementary medicines. And we can go through each of these because, for instance, hypnosis will never cure breast cancer. I mean, there's no data or literature or anything suggested, but on a different form, hypnosis probably can improve quality of life if you're having intractable nausea and vomiting, per se. And you have a hypnotist that could help you with your symptoms related to nausea and vomiting. I would tell someone, what's the downside of trying that therapy? I mean, you only can make yourself feel better. You can move on to the therapy that you need so you can achieve your goals, and you can relax a little with hypnosis, I presume. We're going to talk about marijuana in specific today. We're going to not talk about mushrooms or black cohosh. As you know, black cohosh could help with some hot flash symptoms. And then Chinese medicines or Ayurvedic medicine, we're not going to really touch on much, but these are other forms of medicine, not standard Western forms of medicine, that can certainly be done with patients with breast cancer. And as long as they do not interfere with the therapy and don't interact with the therapy, there really is no downside in using them. So we're going to go to vitamin C, but I think before I get to vitamin C, I just want to make sure everyone's clear that complementary medicine, you know, some patients will say, well, doctor, you don't believe in complementary medicine because you were trained in Western medical thought. I would disagree with that. I think every doctor should say, if it helps you and make you better, what's the difference? As long as there's no downside to these therapies and they don't interfere with your therapy, then there's no really harm to the patient. In fact, there's only a benefit to patients who have an improved quality of life related to their therapies. So let's talk about vitamin C. I think vitamin C is always interesting because I myself thought about opening up a vitamin C clinic. Why? I could be very wealthy. I mean, some doctors in the community charge a nice little load of dollars, and it's a cash business. I have an infusion center. I thought, well, why not? It makes a lot of sense to give vitamin C. It doesn't really harm the patients, as you know. We're going to go through the uses in a second. But vitamin C in itself is not a harmful therapy for patients who have breast cancer, and it may be of some benefit. It's a good cash business. But, you know, at least in my thought process, I'm not here to make money off my patients. I'm here to provide care. There are other people in the community that can do the vitamin C. I'll let them make that money. So what are the uses of vitamin C? Well, I think we're out of the era of scurvy and shipbuilding and colonization era. But really, in the time of, you know, when people were sailors, scurvy was a big thing. That's why they had to have fruits. And this is really kind of the main thing with vitamin C. It can help with common colds. All my patients who are iron deficient or have iron deficiency anemia always get oral vitamin C, at least 500 milligrams of vitamin C a day, because vitamin C clearly helps absorption of iron. So in terms of iron absorption, it's very important. I don't know about common colds so well, but why not? I mean, it's really not such a big deal. Scurvy, I'm not really concerned about in the Western civilization of the United States at this point from a malnutrition standpoint, because we have diets that have now vitamin C included in our products. It may prevent oral cancers, and actually when I did, back in my days of now a long time ago, my fellowship, we used to give our patients vitamin C who had head and neck cancer for prevention purposes in clinical trials. So actually vitamin C does have efficacy in some respects to oral cancers. It could lead to lower lead levels, but we're now talking about it in terms of cancer research. So there are benefits, or there is research in pancreatic cancer, bladder cancer, and breast cancer. And when I'm talking about vitamin C, I'm talking about the oral form of vitamin C. There actually was shown to be no actual benefit in terms of cancer, in terms of progression-free survival or overall survival related to vitamin C. This is a study in patients with ovarian cancer. I found one study in the literature, 27 patients. So by standards of oncology, this is considered a tiny study. It's not a study that we would consider that we would say, wow, this is great efficacy here. But actually, it decreased the side effects of chemotherapy with high-dose vitamin C. So patients who take vitamin C who can lessen their side effects, I don't think there's a downside in taking vitamin C. I mean, there may not be a tremendous upside, but there clearly is not a huge downside in vitamin C therapy. So I would say vitamin C is not a bad therapy to use in patients who have breast cancer. There's no real downside. The only caution I would say is if you have a family history of something called G6PD, which is a enzymatic deficiency of some enzyme that can cause hemolysis or a blood disorder, you should not be on high-dose vitamin C. If you have kidney stones, you should not be on, or renal disease, you should not be on vitamin C. There was something in the literature that before doing a PET scan, you shouldn't be taking high-dose vitamin C. And patients with hemochromatosis, for the same reason, is because vitamin C increases iron absorption in the gut, and thereby patients with hemochromatosis, actually, which is a disease related to increased iron absorption, you don't want to drive that process any further. So there's a few cautions with vitamin C, but overall, I can tell you that most of the population that is G6PD, in fact, I've been in practice about 15, 16 years. I've probably seen one G6PD patient. It's a familial problem, so you'll know it in your patient population. Hemochromatosis is actually very common in Caucasians. So in theory, if you're going to really go full throttle on a high-dose vitamin C program, you probably should be screened for hemochromatosis just to ascertain that you don't have the genetic mutation called C2A2Y or A63D mutation, or a compound heterozygous, meaning one of those two genes related to hemochromatosis. But overall, it's really relatively safe, so there's really no downside. And I'll keep on repeating this theme of complementary medicine. As long as it's safe and you want to empower yourself to do something and you think it's helping you, and you want to pay for it, by all means. So the doses of vitamin C is not really well studied. The doses in the literature is 1.5 grams per kilo. You can give up to 15 to 25 grams in a 30 to 120 minute infusion. Once again, not FDA approved, but it never will be FDA approved. It's almost impossible in a randomized controlled trial to actually study the effects of a lot of these medications because there's so many other outside influences. Meaning you can't tell a patient don't take any other vitamins besides vitamin C. So it's a very hard way to run a clinical trial, and it's also unfortunately not lucrative for anyone to really run these trials because who's going to support it, fund it, and run the trial for $20 million to actually see if vitamin C is efficacious or not. So overall effects are unknown at this time related to vitamin C. It can be given before or after chemotherapy, meaning I would not give it on the same infusion as chemotherapy. You can be given a day before, a day after chemotherapy. It probably will have no impact on the chemotherapy itself as far as we know. The downside is very little. I say you pick up a bottle of vitamin C. Okay, now we're going to talk to a fun topic of hemp and marijuana. Who has tried CBD oil in the audience? Who has smoked marijuana? I don't want to know that. Who has not inhaled but just smoked it? But hemp and marijuana clearly is like the hot topic in oncology as a complementary form of therapy. I'm just going to skip to the bottom because the legality of a lot of this stuff is very unclear. I mean, I don't know. I don't even think our governor knows at this point whether some of the stuff is legal or not legal. What defines legality of this? The CBD, actually, many people can obtain CBD without a cannabis license, so you don't really need the THC component necessarily to get CBD oils. CBD oils, if anyone has tried them, some people say they have efficacy, some people say it doesn't work for them. We don't even know the dosing of how to dose it, how to extract it, what percentage, how many times a day, how to apply it, bake it, eat it, oils. There's no real well-studied with CBD, although it's definitely out there. So I think it's important for us to at least bring it up as a complementary form of medicine. And I'm actually going to show you some studies in actually the literature to see the efficacy of this as an anti-cancer versus an anti-apoptotic mechanism. So hemp and marijuana come in two different strains of the cannabis sativa plant. Hemp contains only CBD, marijuana contains both CBD and THC and other substances, so you get maybe a little more other effects from the marijuana, including the THC, which is the hallucinogenic component. CBD is from the hemp plant. I think also hemp, they're like, you can buy clothing that's made out of hemp, and mats, and carpets, and chairs, and you can do anything with CBD. And this is from the World Health Organization. This is a direct quote. CBD exhibits no effects indicative of any abuse or dependent potential, as opposed to marijuana, which clearly can have some potential related to the hallucinogenic component. CBD does not have that component to it. So once again, the legality is unclear of how to get it. You can probably go online and just type in CBD and you can buy the oils. The problem with a lot of these products is that it is, unfortunately, I can't tell you what the dose is of CBD, what's the percentage of CBD versus THC versus no THC, and what's the efficacy of those. And I'm not sure how well studied those are at this point in medicine. I think everyone likes to experiment and try. I will say definitively that there's probably no downside in trying CBD oils. I think experimenting is okay with it because there's really very few side effects related to it. So the main benefit of these cannabinoids, CBD in specific, is in palliative medicine. And as we know, one of the side effects of patients, and I've never done it, so I wouldn't know, of marijuana is an effect of it can help anti-nausea, it can actually improve appetite, and these are very important side effects for patients who are on chemotherapy. If they're not eating well, that can promote appetite. If they're nauseous, it can have an anti-nausea effect, it can have an anti-anxiolytic effect. I'm told it calms people down and mellows them out. And we're going to go through the studies in a minute, through the literature. I pulled up 3 or 4 studies that showed in preclinical studies it inhibits proliferation of cancer cells, and that's through a mechanism called apoptosis, which we're going to talk about in a minute. So it's used for anxiety and insomnia, and I think these are really excellent adjuvant therapies in addition to your standard therapies that you can give a patient. It's not a cure for cancer, and this is what I want to warn everyone about. All that we're talking about today is we're talking about things that could help patients who have cancer in addition to their standard therapies, whether it's chemotherapy, hormonal therapy, target therapy, CDK inhibitors, or PD-1s or immunotherapies. But in terms of, my patients will say, I want to stop chemotherapy, I just want to do CBD oil. That's okay, but they have to understand that that's not going to get them necessarily better from their cancer point of view. It's going to help them with their symptoms, not really from their cancer. Although, let's go over some of the science behind CBD and cannabis. So this is a nice little schematic. By the way, everyone on the way out, there's a little quiz they have to take. You have to score a 90 or above to leave the room. Patients have stayed here for about an hour to 2 hours. I will help you out and answer the questions with you, and you guys can do it. I'll even give you some of the clues. So this will be on the quiz. This is the cellular membrane right here, and these are receptors for either CBD or THC, and you can see as it goes through the cellular membrane, this is something called a protein called ROS1, and up means it upregulates ROS1, and through upregulation of ROS1, it causes what's called apoptosis, which is cell breakdown essentially. So that's one mechanism of how CBD can work. Now these are preclinical models. This is not, hardcore science that everyone who takes CBD causes apoptosis, cell dies, they're better. 2 weeks later, they're back at work and their metastatic breast cancer is all better. This is a proposed mechanism. This is not hardcore mechanism. And here's THC, also going through the cellular membrane. It's a little blurry, but actually causes something through AKT pathway, autophagy, and then apoptosis as well through the mTOR inhibition and downregulation of mTOR. So this is a schematic to show that there is some science behind these drugs or CBD and THC, and there is some mechanism of action that could actually help patients with cancer. So,
Dr. Cohen, is the CBD alone, does that give you, like, CBD, THC would be traditional from the 60s, 70s marijuana that we know?
right. So CBD you can get alone without the THC.
Does that increase your appetite? Or is it the THC piece?
I am not sure.
Anybody willing to cough that up?
THC, it would
CBD,
probably the THC,
THC,
yeah.
right.
Mhm.
CBD does a lot of the anti-anxiety stuff
Yeah,
and the anti-nausea. I don't think it's the appetite stuff.
yeah.
So you have to pick and choose if you want to be high or you want to be hungry.
Right.
And that'll be the new theme of our lecture.
Why you're hungry. Why you're hungry.
Okay, so and thank you for blurting out. I appreciate it. So if anyone has questions in the middle, just blurt out, and we'll do this all together because that quiz is tough. All right, so cannabinoids inhibit angiogenesis, which is formation of new blood cells by blocking VEGF, which is vascular endothelial growth factor. There's a drug out on the market called Avastin, which is actually an anti-angiogenesis medication, and that's the mechanism of working. So that's one mechanism of action that is a proposed mechanism. In lung cancer, it leads to induction of something called ICAM, which decreases metastasis and tumor invasion. So that's in a lung cancer model, the mechanism of action of CBDs or cannabinoids. It reduces the invasiveness and modulates extracellular proteases and inhibitors, and therefore downregulating the chance of metastases and spread. So this is an early clinical trial of something called GBM, which is glioblastoma multiforme, which is a brain cancer. It's the most aggressive, aggressive form of brain cancer there is, and they used it in conjunction with Temodar, and actually it's exploring whether GBMs with Temodar and CBD oils and the efficacy and not only just the quality of life but also survival benefit of these patients. So this is a concept that is being explored right now in the very preliminary phases. Also in pancreatic cancer, I saw a few studies related to patients with pancreatic cancer and CBDs in conjunction with chemotherapy, not only as a quality of life, but also as a means of trying to see if there's improved survival. So we're not just looking for a benefit of a palliative benefit, i.e. in a quality of life or reduction in symptoms, we're also looking for, does this actually improve someone's longevity of life? So to date, CBD oils I think are great in terms of in the palliative setting for an antiemetic, for sleep disturbances, anti-anxiety medications. There is a component obviously of awaking, perhaps if you use the THC component. I think the cannabinoids or CBDs in and of itself have very little risk and downside. Once again, throughout the literature, there's no dosing schedule, there's no way of dosing it, there's no place to buy it, meaning there are thousands of product dispensaries. So the problem is, as it's not FDA approved, there's not really a way of judging which has better efficacy with one company and the next. It's not like you buy amoxicillin and it's 500 milligrams 3 times a day, and that's what's going to get your infection better. There are various dosing schemes and percentages of these, so really there's no uniformity of what is in the substance here, and that's a little frustrating for doctors as well as patients to see what they're really getting. So we are at this stage in the early stages of incorporating these products into clinical care. It's not going to happen right away because it's all over the map. Delivery systems, including spray forms, which would be cool, that you can just put something up your nose and get 2 puffs of CBD oil and feel better all day. I actually think they should just back up a truck into the reservoir system and dump a truck of CBD oil in it, and then everyone will be happy and good, and that'll be the end of that. I think they should do that with Xanax and Zoloft as well, but I am not going to be the commissioner of the healthcare system, although they're probably crazier than I am. And this is a drug, actually, I brought this up because this is actually the only FDA-approved drug on the market. It came out about a year or 2 ago. It's an oral cannabis drug for patients with specific seizure disorders. I don't know if anyone watched the news, but when this, 2 or 3 years ago, they noticed patients with young kids with intractable seizures actually had a tremendous benefit from the cannabis oils. And that's probably how this whole rage started as a palliative drug to help reduce the symptoms related to things, because patients who were seeing neurologists for years and years and years and getting nowhere, young kids who had intractable seizures, horrific quality of life, were bedbound, couldn't do anything, were in hospitals, in and out. They used to have to, literally, I remember seeing on the news, fly out to Colorado to get marijuana for their child so they can stop their seizure disorder. So this company actually was formed in extracting the cannabis drug from it, and now they just charge like $150,000 a bottle, which is like every drug company who jacks up the price. So probably you'd be better off just smoking it, I guess, than taking the drug, but I'm not proposing that. But nonetheless, this is the drug that is FDA approved on the market today. Okay, so any questions? So far we covered vitamin C and noted that vitamin C itself is actually a safe drug. There are some precautions related to patients with renal diseases, kidney stones, hemochromatosis, or absorption of iron, but overall, oral vitamin C is relatively safe. IV vitamin C is also relatively safe, but kind of expensive, and I guess watch out. Yes?
I was just going to ask you, so with the IV, is it difficult for the body to absorb?
So some patients, IV definitely will get higher therapeutic levels. There's no question about that. And it depends on the patient's GI tract to see what they actually will absorb. You know, the absorption of oral medications is always not as well known as an IV medication. You know, for instance, there are patients that I treat for iron deficiency anemia. Most of those patients should go on oral iron. But if they can't absorb the oral iron, or there's some complication, I know they're getting intravenous iron, which is very simple and easy to give, and I know they're getting all that drug into them. So, you know, sometimes I'll say, well, let's try the oral iron. They got constipated. They said, I can't do this. Then we go to the IV form. So IV form is really an inconvenience more than it is anything else, because you have to sit in a chair for 30 to 120 minutes to get an infusion. There's a much greater cost detriment to the patient in an IV form, meaning IV forms always cost more money than the oral forms, or say typically.
So Dr. Cohen, with the prevalence now and the easy availability of CBD, why would somebody pay that kind of money to get Epiduralex? And
so first of all, the insurance company will cover it if they have that. They have to have, it's a specific form of seizure disorder. I think it's Lennox-Gastaut or some very specific seizure disorder. So the insurance A may cover it. B, you know you're getting the right dose and drug. So you are paying for the product to be correct, as opposed to you have unclear, let's say you say, well, let's open up a marijuana farm and let's fake marijuana into the brownies. You're not really sure the actual dose that they're getting. So clearly there's a benefit of actually getting an oral form of it, but there's a huge expense to it. You know, that has to be weighed against the risk and benefits.
I'll just relate something. I had a family relative just come from India, and they had a relative of theirs that requested that since he was coming here, if he could bring CBD back with him. So I said, well, It seems to be, you could walk into a dispensary and get it. But he says, no, it had to have the THC, that without the THC,
Well,
it
so
was
there is
not
some
good.
controversy in whether the THC actually helps or doesn't help, if CBD oil alone helps. So, sometimes the THC can balance out on a molar form, the CBD oils. So sometimes CBD in itself might not be as efficacious as THC. There's very little literature in studying the exact, because every company has a different CBD oil. So who do you choose to study out of the 250 companies that make, CBD oil? So it's a very open field right now. And over time, with regulation of legalizing it, at least then you can move forward to actually studying it in the right way. It's hard for a doctor to study a drug that's out there but not legalized right now. Because I can't tell my patients, go to Asbury Park tomorrow, and because my patients always say to me, where do I get marijuana? I'm like, you have children? So if you have children, they have a network of marijuana. I mean, there's no way, I hate to say this, but marijuana is more prevalent than getting Coca-Cola. I mean, you can get marijuana enough. If anyone needs marijuana, I won't help them. I will assist them in telling you. I mean, if you have a child or a friend in any high school or college, that will take care of 99% of the market there. I mean, it's so prevalent out there. So, yes.
Have you ever heard of any negative interactions with cannabinoids and
Chemotherapy?
drugs? Yeah.
Yeah, so once again, not well studied. So there might be effects that patients are having. So if I have a patient who's getting their standard chemotherapy for a while now, let's say, and they were getting immunotherapies, and then all of a sudden they say, I'm getting new side effects. And they'll say, well, I just started a new CBD oil. I'll say, stop the oil. Just like we would do for any chemotherapy. We would say, well, stop the chemotherapy and try something else, or switch the product, or go around. So I'm sure there are interactions. We just don't know them at this point. Because once again, it's almost like saying, it's like studying seltzer brands and the efficacy of seltzer brands. Yeah, you can have 3,000 seltzer brands. Since it's not regulated yet, it's very difficult to study an unregulated product. And there's so many vendors and people making it. The licenses are confusing. I mean, does anyone know today, is marijuana legal in the state of New Jersey?
No.
There was supposed to be a vote,
It got
and it got
shut
mooted because Murphy didn't have the amount, enough people to pass it. But the status of this drug is very unclear, and every state has different laws to it. I mean, Ohio, it's approved for medical use. Massachusetts, Colorado, it's approved for, I think, everything. California, everything. Oregon, everything. So every state has different laws. It'd be actually nice if the United States would have one uniform law so we could all follow. So we don't have to go from state to state to actually come up with different policies.
Doctor, I just, one other question on that. So, but in order to get the drug regulated, it would have to go through like trials and...
Not necessarily. Well, in one sense, it can be legal. Once the legality, a lot of doctors are very torn because it's hard to recommend a medication or something to their patient that's not legal. I mean, I look good in orange, so I'm lucky. But not every doctor looks good in orange. Meaning, like, if it's not legal, it's very hard to tell a patient, you should take this drug. So it's a very tough ethical thing for a physician to say you should be on these medications if there are legality issues. God forbid, for instance, let's say a patient of mine is a police officer and he's on chemotherapy, and I say, well, you're having tremendous nausea and vomiting, why don't you try some marijuana? And he would consider it, he or she would consider it, but then if something would happen at the job and they test them, we're at a tremendous impasse. They say, well, my doctor told me. That's not going to hold up very well. So these are issues that have to be overcome. Although CBD oil can go online and it's pretty easy to obtain. It's not a difficult thing. All right, so we got to move faster here. So I'm just going to go through these studies here. This is a study of targeting tumor pathway inhibition in breast cancer. basically, the studies show that THC and CBD can reduce cancer progression through an anti-tumor pathway. Most of these pathways are through apoptotic, which is cellular death. This is another mechanism through O1663 inhibits ID1, which induces apoptosis and survival of metastatic breast cancer. So these are through this British Journal of Pharmacology. You can see that it showed some benefit and is an anti-tumor effect.
Yeah.
This is through another mechanism called EGFR, which is epidermal growth factor receptor, to decrease, to block EGFR, and I'll show you a little cartoon of it in a second. And actually, it was used in patients with what's called triple negative breast cancer, which is a more aggressive form of breast cancer. So here's a little cartoon of CBD blocking secretion of cytokines, so you can't have recruitment or activation. Here's the blocking what's called the EGFR activation, which is blocking metastatic tumor cells. So these are also, once again, proposed mechanisms of downregulating cancer cells through CBD in itself. Okay, so this, what I'm going to talk about now, is also complementary medicine. And the main reason for talking about this is that this is the easiest thing to do for any patient with cancer. And I actually heard this lecture. I was at a symposium at Yale like 2 years ago, and they had these world famous speakers, the most world renowned speakers, and I think this young lady got up there and she was a physical therapist and presented data that beat every other doctor in the room, because she presented this study and how she applied it to her clinical practice of how patients could really improve their and reduce the risk of a recurrence of the breast cancer. So these are just some 3 quick studies I'm going to go over. One is by Holik, which is in Cancer Epidemiology in 2008. They studied 4,400 patients. So these are huge, what's called meta-analysis studies, meaning they take a whole pool of studies. They actually don't study 4,400 patients. They take all the literature and pool it all together in what's called a meta-analysis. With breast cancer, if you achieve greater than 2.8 mets per hour per week, which I've never done in my life, but that's basically 30 minutes of exercise 5 days a week. I still haven't done that yet. And that reduced the risk of dying from breast cancer. This is from the European Journal in 2016. This is 116,000 patients. I mean, that's huge. Once again, a meta-analysis of studying all these patients. Once again, if you do more than 150 minutes a week, that's 30 minutes a day for 5 days a week, there was a 9% risk reduction in breast cancer recurrence. This did not apply to those patients who had hormone replacement therapy. Meaning, if you had hormone replacement therapy in your life, that risk reduction was lost. I'm not sure the reason why, but that's what the literature said. And now we're going to spend a little time on this study by Hammer and Warner. This is published in the Canadian Medical Journal Association in 2017. And I actually I want to give them all the credit for this, because this is the summary of the key findings. Number 1, weight gain during treatment or after breast cancer treatment increases the risk of recurrence. When they say weight gain, they don't mean like you put on 2 pounds or 3 pounds. They mean substantial weight gain to reduce the risk, that increases the risk of recurrence. Patients who are obese or overweight at breast cancer diagnosis have a poor prognosis. If they're estrogen receptor positive, that makes sense, because that's a high estrogenic state. And then it's possible for patients to obtain a meaningful weight loss. And by the way, when I say meaningful weight loss, patients should not want to lose weight in a hurtful manner. They should want to lose weight in a very smart manner and not just drop all their weight, because when they drop too quickly or precipitously, that also will cause problems. And this is the main kicker that I want to really enforce here. Physical activity can reduce breast cancer mortality by 40%. I mean, we give hormonal therapies, aromatase inhibitors, CDK inhibitors. If you could just walk for 30 minutes a day, and when I say just, that's not so easy for some patients who have metastatic breast cancer. They can have, bony mets that are inhibiting them from exercising. That makes it very hard to. But if you could achieve 30 minutes a day, 5 days a week, you're almost doing as much as, I hate to say this, my chemotherapy could be doing, my hormonal therapy can be doing. So it's a very important thing to actually keep moving here. And actually, going back to that lecture at Yale, that person who presented the data actually starts their therapy like from day 1, meaning they got diagnosed in the hospital. They're moving around. Probably related to blood flow, probably related to energy. Obviously, weight loss can decrease your anxiety, make your mood better, can make you tired so you can sleep better. There are a whole host of things that happen with exercise, but this is a 40% risk reduction. I don't know anything else that would really cause a 40% risk reduction. And if you can exercise, I mean, my God, this is like, if the patient says, doctor, I'm trying ginkgo with green tea and this and that, I said, why don't you just get up and move around a little? Because that will be a huge benefit. Yes?
Does it matter, like your heart rate or how fast you're walking or any kind of walking?
Well, I mean, I would say you should try to, achieve some movement there. If you're walking very slow, it's not going to happen, but you build up to a comfortable speed and you push yourself to a healthy rate that you could obtain, and I think that's an acceptable thing. You want to get your heart rate up, yes. You want to get sweaty, yes. You want to get moving, yes. But 30 minutes a day, so 150 minutes per week is all that's needed. Now, this is the kicker. Less than 13% of patients with breast cancer have pain. So, probably one of the things that we as physicians have done poorly is actually telling patients to get up and move around. And we should push our patients to get up and move around because, if 13% of patients are doing this, I don't think it's all on the patients that they're so sick. A lot of it's on the doctors that are not saying, come on, let's get moving here. This is really important for you to get moving, for a reduction of 40%, pretty substantially. Now, I talk to my patients about taking an aromatase inhibitor, and we talk about the numbers, and we talk about the risk reduction. I mean, I had a patient last week, she said, I don't want to put you on aromatase inhibitor, which is a pill, a hormone blocker pill. I said, well, that's fine, but then you're going to get up and move around a lot, because just because you don't want to do my therapy doesn't mean you can't do these other therapies that make sense, that have no drawbacks or side effects, other than you not seeing your family for 150 minutes every week, unless you walk with a loved one, and then you could be with them for 150 minutes more a week. But there's no real drawback. This is straight from the paper that I clipped, so you know that I'm not making it up. And then this talks a little about vitamin C that we talked about. Vitamin E is not associated with any breast cancer positive outcomes. And the next thing we're going to do is to lead off and finalize with vitamin D therapies. Anyone have any questions at this point? Good. So vitamin D and breast cancer. Most vitamin D is obtained through sunlight and diet. So this is an important thing. The sunlight does not exist in New Jersey from the months of November 1st to June 1st. Thereby, everyone in New Jersey is vitamin D deficient. Almost essentially, a lot of people are vitamin D deficient. We do not get enough vitamin D unless you go to Florida once a week. Diet can help obtain vitamin D, and that's through other means. It's a difficult, once again, just like all the other studies, because you can't really, as a controlled or placebo-controlled trial, you can't actually control the amount of sunlight someone's getting. And, so you can't say you have to stay inside for the next 50 days so we can see if vitamin D is working for you. And it's variable. Vitamin D intake is variable in food. You can drink a lot of milk, which is fortified with vitamin D, or you could drink nothing that has vitamin D in it. So it's a hard thing to study. There are many trials. This is a study from the University of San Diego and Creighton that all patients were who had higher levels of vitamin D had cancer-free and were followed by 4 years. And this is the largest trial. Actually, it was published in the English Journal of Medicine this year. It's called the VITAL trial. This was actually to show the incidence of patients, not who had breast cancer, but overall incidence in the general population. And vitamin D did not lower the incidence of cancer. So this did not address whether if you have cancer, it lowers the risk of recurrence. To me, it addressed the issue of whether taking vitamin D actually prevents having cancer in the first place. And this is a meta-analysis by Chen et al. That higher vitamin D was associated with a 45% decrease in breast cancer. So not only is the literature all over the place in terms of risk reduction, I can find you 5 articles that show no risk reduction. I can find you 5 articles that show a risk reduction. But it's all over the place, and the dose level that you need that's shown, and I use the level of 30 because 27 is an odd number, and I don't like to be odd, is 27 nanograms per ml. So a dose of 30 nanograms per ml of vitamin D levels is usually enough to ward out, or perhaps I should say, lower the risk of vitamin D. There was no real side effects of taking vitamin D. Yes?
How does using sunscreen affect the ability for the skin to produce the vitamin D?
Lowers it. So, well, it's like a seesaw. You're preventing melanoma by using sunscreen and other skin cancers, but you're also preventing vitamin D. So you have to use other ways of supplementing your vitamin D into your system. Okay, so we're going to finish up here. Complementary medicine is adjunct to standard therapies. They're used to help support patients during and after treatments, and I think they're vital. They're useful in improving quality of life and reducing symptoms. They're in addition to and not in place of therapies. And I think any complementary medicine that I talked about, whether it's pet therapy, art therapy, Tai Chi, yoga, these are all helpful for patients. And actually it empowers my patients to take a leading role in their cancer care. I mean, I can take care of the chemotherapy, and I can talk about chemotherapy from today until tomorrow. It's a team effort between a patient and a doctor. And if you would walk 30 minutes a day, 5 days a week, there's a positive impact there. If you take some vitamin D and keep your levels up, there's a positive impact. So all my patients, I always tell them every time, I say, unfortunately, you only can check vitamin D levels in Medicare rules, I think twice a year, or by some insurances. So we check the vitamin D levels twice a year to see what it is. There's 1,001 formulations of vitamin D out there. Actually, a friend of mine I was so excited a few weeks ago, he bought a vitamin D, soluble vitamin D company. It's like a odorless, colorless, water soluble. You just dropped it in the water, and I gave it to some of my patients to see if it worked. I haven't heard back from them yet, but there are a lot of vitamin D formulations out there. Whether they work or not is difficult to know, but I would tell you that there's no harm or downside in taking a lot of these complementary medicines as long as you and your doctor are aware of what's going on. Thank you very much.
Just real quick, what's the range of vitamin D? Where should we be?
So above 30 is where I would tell you where everyone should be, because a lot of the literature shows anything above 30. Now there's some literature that shows that if I'm on call, sorry. That's why I'm here today, actually. There's some literature to say if you drive vitamin D levels like to about 60 even, you have a great benefit. That literature is a little shaky to me. I mean, I would tell patients, to go, the usual doses of vitamin D are between 2,000 and 4,000 a day. People take, the Endocrine Society actually put out some guidelines a few years ago. They do 50,000 a week for 8 weeks, and then, retest at that point. The problem is you can only retest so many times a year, so it puts you in a little pickle, because if you retest now and then 8 weeks later, essentially you have 44 more weeks of not knowing where their vitamin D level is. But I think, this is not hardcore science. It's just easy things to do, and it's easy to walk. It's easy to take some vitamin D. It's easy to take vitamin C on occasion. I mean, these are not very difficult things. And once again, it gives back the power to the patient to get some control and quality of life. Yes?
I take a probiotic, given all of the crap that I'm taking for everything else. I figured my stomach needs some help. Is that off the wall?
No. It's great. Enjoy it.
My stomach doesn't.
See? But you see, that's the point of complementary medicine, in my opinion. Complementary medicine is not for a doctor to tell you what you should be taking. It's so you have a quality of life that you could continue doing exactly what you're doing and not be suffering in regard to, the therapy. So if it doesn't interfere with your therapy, then there's no reason why you can't do these therapies.
Thank you.
Can you expound on review on stuff like do you see sugar intake and animal product, cheese, milk, that kind of
Yeah, so the sugar theory, I was born way after that. Meaning, a lot of people say sugar feeds a cancer. Of course it feeds a cancer. If you look at how PET scans are done, in fact, PET scans are based on what's called SUV avidity, related to the amount of glucose uptake or sugar uptake or metabolic uptake there is in a tumor. That's how we look at it. The problem is, technically speaking, your body needs some form of sugar to actually continue. I mean, it's a balance between sugars, fats, You know, so it's not as, and protein, so it's not as simple like stopping sugar and you're fine. And it's very hard really to, on a scientific level, to study these things of whether, well, you can say, I always joke with my patients, I say to them, well, you know, they say, well, I want to have an alkaline diet. I said, well, if your pH goes to 8, you will kill all cancer cells. Promise you. But there's a hooker, there's a kick to it. You will also die. Meaning you can't live with a pH of 8. So there's got to be a balance here of the reality of the situation. You got to eat food, and you got to be smart about it. So these are not well studied. You know, the sugar thing is, it's a good theoretical issue because, you know, sugar obviously feeds cancer, but so does fat, by the way, so does everything else. And then the question is, what do you eat if you're not eating anything? And you could starve yourself and that wouldn't feed anything, but in reality, you're not really helping yourself. So there's got to be a better mechanism to go about that sense of sugar feeding the tumor. Meaning, that's not the right approach, but it's not on a theoretical level, it's not totally correct.
Right, I don't mean cutting out all sugar, but the reductions of it and the minimizations of it, is there?
Yeah, so once again, you know, eating healthy, no one would ever disagree with. And eating smart and wisely, no one else would say against it. The question is, how much does that do in terms of tumor progression, proliferation? Once again, very hard to study this because you really have to study someone's diet on a daily basis, 3 meals a day for a year, and then see if there's, and you have to have enough patients. And how do you really study that? You have to actually live in their house or put them, it's almost like you have to have them at a center for all their meals to see which meals work or don't work. It's a very difficult way to study it. So these are unknown things that will probably stay unknown for a while because of the inability to really run a well-conducted, you know, controlled, randomized controlled trial to these things. Okay, thank you very much, everyone. I appreciate your time.